Hi, I'm Dr. Dean. I'm an eye surgeon working in Nelspruit in Bombela, and today I want to talk to you briefly about retinal detachment repair or retinal detachment surgery. So a retinal detachment is a potentially sight-threatening condition, and majority of the time requires surgery, almost always. And that surgery most of the time nowadays is a pars plana vitrectomy. If you want to see more details specifically on what a PPV is, you can see one of my other videos. But today I'm specifically going to be talking about retinal detachments. I think firstly to understand what are the symptoms of a retinal detachment, because the sooner we get to a retinal detachment, often the better the outcomes of the vision in the long run. And so being aware of those symptoms is important. So the first one being flashing lights. So this is often described as lightning or sparklers or sudden flash. It can be crescentic, normally in the periphery of the vision and often with eye movements. It's often accentuated or made worse at nighttime when it's present when people close their eyes. And so that's one of the early symptoms, and that normally indicates traction. What that means is that something is pulling on the vitreous, is tugging on the vitreous, and that's causing a flashing light. The other one is a floater. As the gel comes away from the back of the eye, you can get release of floaters. Sometimes a little blood vessel can tear and there can be some blood, and so that can also be a large floater. So new floaters is another symptom, and probably the most ominous one that is most sensitive to say that a patient actually has a detachment is a dark shadow or curtain coming across the eye. So patients describe there's this black curtain that slowly moves across the vision from one direction, normally from the bottom or from the top or from the side, and it slowly moves across the vision, and that's very ominous and very suggestive of a retinal detachment. And if you have any of those symptoms or those symptoms together, you need to get to an eye specialist and a retinal surgeon as soon as possible, because there's a good chance that you've got a detachment that requires surgery to repair it. Retinal detachments can happen in anyone in the population. There are patients who are higher risk than others, and there's a variety of risk factors. The highest risk factor is someone who is myopic, and the more myopic you are, the higher the risk factor, the higher the risk. A myopic patient is someone who's short-sighted. Their eyes are normally longer, and they have abnormal adhesions between the vitreous and the retina, and they're at higher risk of developing a hole or a tear, which is what starts a retinal detachment. So just to show you this diagram, it's interesting just to see what this process looks like. So a posterior vitreous detachment is not a retinal detachment. That's when the vitreous detaches from the back of your eye, and it's important not to get those confused. If you've been told you have a posterior vitreous detachment, that is different to a retinal detachment. A vitreous detachment can lead to a tear, which then can lead to a retinal detachment. And so it's important just to understand that. So here again, this is just a diagram of the eye. You can see this is the vitreous, this is the gel that fills the back of the eye. At some stage, as the gel becomes more liquid, normally that happens over time, it becomes, there's more fluid-filled pockets. At some point, the gel peels away from the back of the eye. As that gel peels away, we call that a vitreous detachment. The vitreous is detached from the back of the eye. And commonly, one can get a whole lot of floaters all of a sudden when that happens. Often there's a vice ring, which is a particularly large floater, which normally sits around the optic nerve. As it detaches, you can get this large floater, and patients can describe a little ring or circle, oval, or a crescent that moves in the eye. And as you move your eye, because as you move your eye, the gel in your eye moves around, it floats around, and so you see these floaters moving backwards and forwards in front of your vision. What also happens at the same time is as your eye moves, the gel moves. As your eye comes to a stop, the gel keeps moving, and what can happen in this area over here, the gel can pull or tug on the retina there. If it tugs on there, you can see a flashing light, and that's where that flash comes from those where those flash symptoms come from. In certain scenarios, if it's very adherent here, and it doesn't peel away, what can happen, instead of it just tugging on the retina, it can tear a hole in the retina, and that scenario looks like this. So here you see the gel has pulled away, but as it's got to this point, it's torn a hole in the retina. Now that there's a hole in the retina, fluid from this compartment can move up underneath the retina and start to detach the retina. This orange layer here is where the retina is, so as fluid accumulates here, this detaches more and more and more, and then until the whole retina detaches. And so that's what a retinal detachment is. In this scenario, one needs to operate. One needs to remove the gel, doing a vitrectomy, so we can remove the traction that is pulling on that tear. We need to remove the fluid underneath here by sucking on that hole and getting the retina flat again. Once the retina is flat, we can apply laser around the hole, and then we use a gas tamponade or an oil to keep the retina flat while the laser is sticking down. So laser, you can think like welding. We apply these welding spots around the hole, but it doesn't stick immediately. It's not like welding and the retina sticks. It takes some time, and so you need to have something in the eye in the interim to allow the retina to stick down before it redetaches. Here's just some images of actual detachment. You can see this part of the retina is detached, and you can see the hole or tear there. Here's another image where you can see the retina is detached and there's a tear in the periphery over there. What's very important is detachments are split between two groups. There's a macula on and a macula off. If your macula is still attached, your chance of good visual recovery after surgery is very high because your macula is responsible for your central vision. In this patient, it looks like the macula is still attached. This is the macular area. Once the macula detaches, the prognosis for good vision, even with repair, is a lot less. You still require surgery. The vision should still be a lot better than before surgery, and sometimes can return close to normal or to normal, but it's much more variable and less likely to have normal good vision. Whereas if you have a macula on detachment, if we get to your retinal detachment before the macula detaches, your chance of good vision is much, much higher. At the end of a retinal detachment repair, once we've flattened the retina again, and we use heavy liquids, which are special liquids that sink down, we use air and other gases and other mechanisms to flatten the retina. Once the retina is flat and we've applied laser, we need to use a tamponade. And a tamponade is either going to be a gas or an oil, depending on the type of detachment, whether there's scar tissue, how long it's been there, where the holes are. There's multiple factors that are considered before deciding on whether one uses gas or oil as a tamponade. The advantage to using gas is that gas dissolves, comes out the eye by itself over a couple of weeks, sometimes months if we use different gases, but it dissolves by itself, so often you don't need to go back for a second procedure. If one uses oil, you have to go and remove the oil. So the oil needs to be taken out a couple of months later. The advantage to oil is that you can travel. Going up to altitude, flying, there's no problem with traveling with oil, but you have to go and remove the oil later on. Gas, you don't need an additional procedure, but you cannot travel, you cannot go to altitude, so if you need to fly, if you need to travel, that may be a consideration, and also determining what tamponade is used. But I'm going to do a separate video specifically on gases and oils, so have a look there if you want more information on that. But that's the basics of retinal detachment and retinal detachment surgery. I hope it was interesting, and if you need more information, please feel free to contact us.